Continuing with the traumatic cataract, what are the indications for the surgery in a patient with traumatic cataract? If there is an unacceptably decreased vision, if there is an obstructed view of the posterior pathology, if there is a lens-induced inflammation, that is uveitis or glaucoma, if there is a capsular rupture with the lens swelling, if there is a other trauma-induced ocular pathology which necessitates the surgery. Okay. The next is what surgical care we have to provide. We have to first see the preoperative capsular integrity and the zonular stability. In case there is a posterior subluxation, that is dislocation without glaucoma, inflammation or visual obstruction, surgery can be avoided. If there is standard phacoemulsification, if these are present, standard phacoemulsification can be performed if the lens capsule is intact and there is sufficient zonular support. ICC has to be done if there is an interior dislocation of the lens or there is extreme zonular instability, because the standard phacoemulsification can cause pupillary block glaucoma. In such cases, the pars plana lensectomy or vitrectomy may be the best indicated in cases of posterior capsular rupture, posterior dislocation or the extreme zonular instability. Automated irrigation or aspiration can be used in the patients younger than 35 years because in those patients the nucleus is not hard after the trauma. It is just the intumescent white cataract and not the white hard cataract in such patients. And we have to, after the cataract removal, we have to implant the lens. Next, in glaucoma may also result from the injury to the eyeball, and such glaucoma can be due to such glaucoma can occur because of the closed globe, either earlier or later. What are the early cases in a closed globe injuries? It can be due to the traumatic uveitis. If there is a disruption of the trabecular meshwork, if there is a hemorrhage associated and there is a lens associated. If the later onset closed globe injury glaucoma can be present because of the angle recession and the closure of the cyclodialysis cleft, or hemorrhage associated, can be the ghost cell, hemolytic and hemosiderotic, and the lens associated glaucoma, late onset closed globe injury due to subluxation, phacomorphic particle and uveitic glaucoma. The open globe injury can also cause glaucoma because of the inflammation, flat interior chamber, epithelial downgrowth into the interior chamber, intraocular hemorrhage, which can further lead to the ghost cell glaucoma, hemolytic glaucoma, or the hemosiderotic glaucoma, or the intraocular foreign body. Glaucoma can also be caused because of the chemical, thermal, or the electrical injuries. Okay. How do we manage traumatic glaucoma? We use the medical therapy to reduce the IOP. If there is satisfactory reduction of the IOP, we continue with the medical therapy. If there is a failure to reduce IOP, we determine the amount of angle recession or extent of the injury. If there is a significant damage or extensive injury, we do the trap with anti-metabolite. If there is a relatively mild trauma, we use the trap without anti-metabolite, and we normally control the IOP, and this can avoid the long-term risk of infection when the blood fails. There can be a vitreous hemorrhage in the eyeball after the trauma. It is due to the extravasation of the blood into one or the several potential spaces formed within or around the vitreous body. What are the signs and symptoms? Vitreous hemorrhage patient presents with the complaint of visual haze, floaters, cloudy vision, or smoke signals, photophobia, that is glare to the light, and perception of shadows and cobwebs. Jale dikhte hain. Small vitreous hemorrhage often is perceived as a new multiple floaters. Moderate vitreous hemorrhage is usually perceived as dark streaks. Dense vitreous hemorrhage tends to be significantly decrease the vision even to the light perception, and we have to evaluate ophthalmoscopically within the to see the blood within the vitreous gel or the anterohyaloid or the retrohyaloid spaces. What is the treatment of the vitreous hemorrhage? No treatment is given unless there is a very extensive hemorrhage. Even the choroidal ruptures, if present, if they are not prolapsed, no need to repair, just wait. Usually the vitreous hemorrhage clears without therapy. What are the indications for the surgical removal of the vitreous blood? It is removed when there is a vitreous hemorrhage associated with the retinal detachment, if there is a long-standing vitreous hemorrhage with a duration greater than 2 to 3 months, if the vitreous hemorrhage is associated with rubeosis iridis, If the vitreous hemorrhage is associated with any type of hemolytic or ghost cell glaucoma, how do we proceed with the removal of the vitreous hemorrhage by vitrectomy? Nil per oral, antibiotic coverage, tetanus prophylaxis, antiemetics, any ocular ruptures, okay. And next we come to trauma to the retina. How is retina affected because of the trauma? There can be many tears or holes in the retina due to the trauma. Either blunt or penetrating will surely cause the break in the retina. Macular hole may result because of the blunt trauma, because of the active concussion, and the commotio retinae may be commotio retinae. What is commotio retinae? It is the edema of the outer retinal layers because of a blunt trauma, and it gives a picture of a cherry red spot in the retina, and it resolves spontaneously. This picture shows a choroidal rupture. It is concentric to the disc. Notice the concentricity to the disc, and the choroid appears here. There is a fiberoptic band. When there is a choroidal rupture. There is a macular hole associated in this case along with the choroidal rupture because of the blunt trauma or ruptured globe. And this shows the FFA of the choroidal rupture case, in which the macular hole is also could be seen along with the choroidal rupture. And there is a associated CNVM along with the choroidal rupture in this case. What else can trauma present with? It can present with the suprachoroidal hemorrhage. Here this is a hemorrhage of an intraoperative expulsive subchoroidal hemorrhage. Even operating is a type of a trauma to the eye. It's not that the operation is not of a trauma, but we are legal trauma experts. So we traumatize the patient only to heal and not to actually traumatize the patient. Hence the suprachoroidal hemorrhage. You can see the suprachoroidal hemorrhage after the cataract extraction. ECC was being done in this case, and suddenly the suprachoroidal hemorrhage erupted and we had to close the wound immediately. This shows the B scans, the initial appearance of the suprachoroidal hemorrhage with there is a very dense clotted blood, and the same eye 10 days later when the clotted blood liquefies. Okay. What are the risk factors for developing a suprachoroidal hemorrhage? The systemic risk factors can be advanced stage on any anticoagulation, any atherosclerotic disease, blood dyscrasias, diabetes, hypertension. The ocular risk factors could be aphakia or pseudophakia, choroidal arteriolar sclerosis, any history of previous vitrectomy, increased axial length, that is high myope, and increased preoperative IOP. What are the perioperative or intraoperative risk factors? There is a acute drop in IOP, general anesthesia, hypertension, intraoperative tachycardia, retrobulbar anesthesia without epinephrine can also be a risk factor for traumatic subconch hemorrhage, suprachoroidal hemorrhage, Valsalva maneuvers, any vitreous loss. What are the postoperative risk factors for traumatic suprachoroidal hemorrhage? It can be hypochrony, tissue plasminogen activator use, or any Valsalva maneuvers post-op. What is the prophylaxis against traumatic suprachoroidal hemorrhage? Preoperatively, the prophylaxis is to discontinue any aspirin or anticoagulants whenever feasible, lower the IOP if possible. Intraoperatively, we can use epinephrine if the retrobulbar anesthesia is applied, and maintain an intraoperative pulse rate of less than 90. Avoid any systemic hypertension and avoid any surgical trauma. Post-operatively, avoid Valsalva maneuvers and avoid hypotony. What are the late and poor prognostic signs in the patient with traumatic suprachoroidal hemorrhage? It is the tissue exclusion and the appearance of the fresh blood. What are the foreign bodies which can traumatize the eye? It can be a nail in the eye, and we can see some occult bodies which can be seen only on the corneal lens traumatizing the eye. What are the superficial foreign bodies present as? It presents as sudden discomfort and reflex blinking. The superficial foreign body sticks to the palpebral conjunctiva, and the palpebral conjunctiva, when it drags on the cornea, causes a corneal ulcer. and the most common location is the middle of the upper tarsal sulcus. If it is not removed, infection can result in the form of conjunctivitis. We should use a fluorescein stain to assess the location. We should anesthetize the cornea with the oblique illumination. We should remove this. The lower phonic swab can be used and the upper lid has to be double everted using the Descemet's retractor. If the foreign body is on the bulbar conjunctiva, we can use a fine forceps or spud or needle and remove the foreign body. Antibiotic ointment has to be given. Magnetic removal in case of the iron bodies can be done. Prophylaxis in industries to remove the foreign to help in less trauma due to the superficial foreign bodies can be the banning of tools with any overhanging edges, guards on the machines with grindings, and the goggles. Severity of inflammation depends on the type of the foreign bodies. There is a severe inflammatory reaction which can result in endo in cases of iron, steel, copper, or any vegetable matter. There is a mild inflammatory reaction in cases of nickel, aluminium, mercury, or zinc. The carbon, coal, glass, plaster, platinum, porcelain, rubber, silver, stone are inert metals. Even the inert foreign body can be toxic if coated with a chemical additive. Beware of that. Conjunctiva or cornea, we have to see the mechanism of the injury, the visual acuity, the slit lamp exam, the fundus exam to rule out if any foreign body is entered into the eyeball. We have to check for the ruptured globe and we have to remove the foreign body under the slit lamp. Sometimes using the tuberculin syringe and a 26 gauge needle with a topical anesthetic. If the foreign body is intraorbital or intraocular, I always have a high index of suspicion, especially if the mechanism of injury is suggestive of the foreign body. Do not harm the eye more than the foreign body. The tests CT, MRI can be done, B scan can be done. Surgical intervention is to be done with a vitrectomy if there is actually a foreign body, intraocular foreign body. If it is intraorbital, we can do the orbitotrectomy like in missile injuries, and infection coverage has to be taken care of for sure. What are the main goals of treatment? Four main goals of treatment are preservation of vision, preservation of vision. We have to prevent any form of infection. We have to restore the normal eye anatomy as far as possible, and we have to prevent the long-term complications because of the surgery or the trauma. At last we come how the trauma can affect the other eye, the non-involved eye. The other eye can be involved as a case of sympathetic ophthalmia in less than 5% of the penetrating injury. What is sympathetic ophthalmia? It is a bilateral granulomatous uveitis. For example, my right eye is injured. The granulomatous uveitis will be present in both the eyes. There is an interior chamber inflammation, multiple yellow spots in the peripheral fundus. What are the complications of the sympathetic ophthalmia? Any complication of uveitis is a complication of a sympathetic ophthalmia, that is a cataract, glaucoma, optic atrophy, exudative detachment, subretinal fibrosis. And the 80% of the cases with sympathetic ophthalmia are present within 3 months and 90% within 1 year of the initial injury. How can we treat sympathetic ophthalmia? By using systemic immunosuppression with steroids or immunomodulators. There is mostly a good prognosis of more than 6/18 vision when under therapy. However, we can enucleate, but enucleation is done only if there is no visual potential and no visual potential. Hence, we complete the eye injury topic. Next, we will make on the topic with neuro-ophthalmology, that is the optic nerve disorders.